At least some of the surgeons here are commonly seeing intrusion of the balloon into the middle ear, and even deliberately or finding that advantageous to see that, and it concerns me a bit. So it reminded me that we did this study. This was a cadaveric study, so it's hard to know if that's applicable to live humans, and it is possible that in the cadaveric process, these were fresh frozen, but still they get frozen, and that can reduce the tissues, and so perhaps that's why. But we had 100% incursion, and we were using the Spiegel balloon, which is the small balloon, and not supposed to be able to go through the isthmus. And we applied it in the standard fashion with all of the safety precautions of having the introducer in the nose, not too deep, exactly as we would do in a live patient. And in every single case, the balloon went through to the middle ear. And then we sort of classified how far it went in. In one case, it even perforated the tensor fold. But I think it's just a word of caution, really, that although the balloon might only be 2 centimeters in the case of the Spiegel balloon, the actual length of the apparatus that carries that balloon can be almost double that size. It's about 38 millimeters. So you just need to be aware of that the tip might be much further in than you realize. So what it brought up in my mind is, and we've come back to it quite a lot, was the CT scan, and I think increasingly CT scans are going to be important in these cases, and maybe it's just until we have more knowledge, because we're still in that grey area of fog. I think the more data we collect, the more information we have, the better. And so, although I know I think that Germany no longer does CT scans preoperatively, maybe we do need to, because we just need to understand what's going on a bit better. But that was one question. And then the other thing is, I really like the way Dr. Batman has an endoscopy in the ear. And the question for the group, and maybe this afternoon when we're doing the consensus, is maybe that should be mandatory. Like maybe, think of another procedure where we have an opportunity, very easy opportunity, of seeing what we're doing in the ear. Why are we not doing that? I certainly don't do that. And it would be very easy for a resident to hold a camera in the ear, and it would avoid many of these complications. So there are cases of hearing loss quite commonly in the literature. They're probably due to incursion, because it is more common than we think. So that was really the thought.
We're running out of time for discussion. I know, Holger, you presented these slides yesterday, so there maybe isn't time to sort of go into a lot of detail now. But do you have any comments in relation to these last two talks about the risk of injury to the ear?
I think it makes sense. What I started now about 4 months ago is that I do a split screen. So I bought a new endoscopy tower by Atrex that is actually giving you the opportunity to have 2 parallel endoscopies, because otherwise you need 2 endoscopy towers, which is a lot of hassle, I think, in an operating theater. So they have a device called NanoPro that can stick into the external ear, and you can observe the external ear while you do the balloon. So I think that's really helpful. That's probably going to reassure us that we don't see those complications anymore.
Thank you. Yeah, and I think other companies you can get split screens as well, can't you?
I mean, that's super expensive, right? But talking about developing worlds and so on, you can have a microscope. You can have your resident with a microscope in the ear, because you're in the nose with the endoscope. Right? Don't forget, there's easy ways to look in the ear.
I think the cheapest and easiest way to do it is just to have a calibration on your instrument, so that you know how far it should go in. It shouldn't be more than 25 millimeters that goes into the cartilaginous eustachian tube. If it goes beyond 25, you're starting to get into the isthmus. And so even if it doesn't have a deliberate mark, you can look at your device and see what corresponds to that 25 millimeters length and look for it.
In an adult, and maybe over the age of 8, but young children, we need to remember an adult balloon may be
So that's an excellent point. So you'll need to calibrate something even commensurately smaller.
So I think we've got the last sort of minute or two, and I'm going to summarize by referring back to the comment you made, actually, Dennis, in terms of how we get the answer to these questions. And my perception is that to find these red flags and figure out the risk-benefit ratio, we do need prospective comparative studies to answer the questions about efficacy when compared with other treatments or when compared with the natural history. But in order to understand the risks, then we do need a large series of data with people like Holger's done, very honestly revealing what problems have occurred. And I was going to ask the panel what their perspectives were, but I think because we're out of time, I'm just going to suggest that maybe the risk-benefit ratio is different for different conditions, and we might all have different, there might not be a consensus on where we are for these different conditions, but this really is where we do need to focus our work in order to be able to find out where the risk-benefit ratio lies in different forms of eustachian tube dysfunction. Is that an okay summary? Okay. Well, thank you to the panel. I really appreciate the valuable experience and different perspectives.